So get plenty of rest. All of these things, right, on the responsibility, laying the responsibility squarely at the feet of individuals. Why don't you just? And we recognize that as professionals in a prevention system, that it takes more, that if we're going to look at personal responsibility, then we have to really begin to think about social responsibility. But we're really sort of praying to think about in this downstream place. We actually in Michigan are having lots of conversations around the Coronavirus Relief Fund, but so many of the criterion for using that funding is very, very downstream. Buy more masks, buy more, help people sanitize, mark spaces for social distancing, but not allowing us to pay for systems changes that would make prevention the default, right? So downstream thinking, Rachel Molina-Chan is in philanthropy, and she says it's this tendency that we have as individuals and as decision makers to focus on one-off, individual lifestyle-based short-term solutions. Those are the easy fixes. Rather, she says, than long-term interventions that address root causes of well-being. So if we start a root causes journey, then we have to think not just about are you eating, exercising, seeing your doctor, and getting plenty of rest, but what is the walk home from school? Is it riddled with glass and obstruction, or is it beautiful and manicured? What does the business district look like? Is it vibrant and welcoming? Is it boarded up and neglected? What even does the indoor environment in which people are living? And, I really almost picked this picture as an homage to Flint and the water crises and the challenge that communities and families were having with just getting clean water that wasn't rusting out things, right? What also is the view from your backyard? Is it welcoming? Is it restful? Or is it filled with toxins and all types of outdoor air challenges? What is the school district even like? And I showed this picture particularly because at the top we have a school that is an LEED certified, modern, contemporary learning environment. At the bottom, we have a school that was literally built next to the county jail. I just wish I could have been a fly on that wall. Like, who thought building a school next to a jail was a good idea? So what are these decision-making spaces that we are getting at? How do we stop thinking about the easy, low-hanging fruit, and how do we think about getting up to the top of that tree? So how do we focus our attention on reducing disparities at both, not just social determinant level, but will that also reduce health inequities? So I want to really challenge your thinking and the depth of your thinking because many of us are squarely stuck in the space, and not stuck, but squarely engaged in the space of social determinants of health. It's a decent space. It's a good space. But if that's all we're focusing on, will we be reducing health inequity? So just let that question ruminate in your mind for a second. So we've been pushing and trying, I've been trying to get people to think about that whole continuum. Like what are we trying to make mainstream in this space? Right now, social determinants of health are mainstream. People are like, oh yes, we're so progressive, we're doing these great things, but are we? So if we look at the continuum of what's causing health, most of us are taught and educated to focus on psychosocial stress, because psychosocial stress and unhealthy behaviors then contributes to the inequities that are showing the distribution of disease, illness, and well-being. What we are trying to do is move people from psychosocial stress and unhealthy behaviors, because that is downstream. It needs to be done, right? This is both and, but it is downstream. So if that's all we're doing, then we're missing many opportunities for lasting change and prevention. So social determinants of health, if we move from psychosocial stress and behaviors upstream a little bit to social determinants of health, that still is really only getting us about midstream. That is not upstream work. We have to begin to think about, why are there disparities and inequities in, say, housing and education and transportation and access to care? The why behind that gets us a little closer to upstream. And that is really thinking about, what are the power and the wealth imbalances? Why are tax policies favoring the wealthy and not favoring those who are not as financially well off? Those are policies that look at power and look at wealth imbalances in our society. And then if we push even further to that, the root cause we see is the social structure in our society. We always say, well, we don't have a caste system like in India or other nations, but we do very much have parts of our society that are othered, that are encapsulated, that are pushed to the side, and that has a lot to do with our unresolved consequences of racism, classism, and gender oppression. These things continue to happen. They are documented, and not just at the interpersonal level. We're not just talking about stop using the N-word and be polite and let's try to be civil. It really is looking at systems that were designed to benefit groups of people over other groups of people. And that, I submit, is what we're trying to make as mainstream, those root causes. So I hope this is giving you a framework to think about where you are in your work and how can you really push to a deeper level. So upstream root causes, if we think about what the mainstream is, right? The mainstream is sort of this principle or dominant course, the tendency, the trend, the automatic space, that's where our thinking goes. And we're trying to say that we've got to think about oppression. People don't want to think about oppression. It's hard and it's depressing and it's sad and it's discouraging. Let's just think about the good things. Well, if we don't have an authentic dialogue as a nation, as professionals, about these issues of racism, classism, and gender oppression or genderism, then we will continue to spin in this circle that is not that is disadvantaging all of us, because racism also hurts white Americans as well as Americans of color. Classism hurts all Americans. When we look at Sir Malmert, I'm forgetting his first name, but he was on the World Health Organization. He chairs the Social Determinants of Health Committee, Malmot, M-A-L-M-O-T. He has this linear study that shows that even if in a society where there are huge gaps between classes, that the wealthy don't do as well as they could do if the middle class were doing better. And the middle class don't do as well as they could do as the poor were doing better. So it's all this link of relationship. And of course, gender continues to happen. Had my own experience with salary inequity when I found out that as the deputy health officer, and there were two of us, that my colleague, who happened to be a white man, had a significant higher salary than I had, even though our job descriptions were the same, our responsibilities were very similar, just different areas of the department. And so it is this need for intentionality to help us advance change and become both anti-racist, but also anti-oppression. So I tend to describe my work as anti-oppression, but we also have to be explicit in our conversations about race, but I would submit that we can't be exclusive in those conversations. Again, we're trying to do both of these things. So let me just frame a couple of definitions, because one of the things that we find is everybody saying health equity doesn't mean health equity. And everybody saying health inequity doesn't mean health inequity. So I just want to be clear with you on what I'm meaning in those spaces. And this is a pretty old and fundamental definition. This came out in the 90s when we first started these dialogues. And I just love what Margaret Whitehead has done with this definition. She says that health inequity is differences in population health status and mortality rates that are systemic, they are patterned, they are unfair, they are unjust, and they are actionable, as opposed to random or caused by those who become ill. The beauty of what Margaret Whitehead did was she invited values to the table. You know, we have these sort of, you know, professional demeanor rules, right? And, you know, professional self, personal self, these are supposed to be non-emotional. It's about facts and data. And Margaret Whitehead says, no, we've got to have all of that because we have to believe that this is unjust. And I was pleased to see some of you add that word to the Slido cloud. It's unfair and it's unjust. This is not acceptable. And those of us with power, and if you're on this webinar, if you're attending this summit, you have privilege and you have power. So it is unfair and it is unjust. And we do see the same patterns and the same systems. The trends that you all are seeing in Southern Nevada, I bet are very similar to the trends I'm seeing in Michigan. It is a systemic consequence that's measurable and that we documented over and over again. But most importantly, it's actionable. We can do something about this. People will sometimes in this sort of hopeless space say, well, we can't change poverty. Well, we can't fix racism. Huh, of course we can, right? These are all man-made, person-made phenomenon, and we can take the steps to reverse them. Another really important frame, and this definition I love, Paula Braverman from UCSF was funded by the Robert Wood Johnson Foundation to pull together a team of experts to really talk about bringing some unity to the dialogue, right? And I'm honored to be a part of that advisory team that came together. And we landed at this place that health equity means that all have a fair and just opportunity for good health. That seemed like it hit it on the nose, it hit the nail on the head, but it also let some people off the hook. So we wanted to further push and say, you know, health equity has to be the ethical and human rights principle or the value, you know, just like Margaret Whitehead, we're adding values to the table. It's the value that motivates us to eliminate health disparities. Health equity is the so what and the why of this disparity conversation. And so what does that look like? How might we do that? She further says, well, it requires us addressing and removing obstacles to health, like poverty, like discrimination, like the consequences of those things, powerlessness. As you're engaging communities and you see the challenge that they have with elevating their voice and their needs, that's powerlessness. Lack of access to good jobs. It doesn't matter how much you're personally out there beating the streets trying to find work, if there aren't good jobs with fair pay available. Quality education and housing, safe environment, access to quality health care. So she pushes us in this space, right? And again, it is this moral drive, this moral imperative that we have to do something about this. And we say always that you can't do this work, you can't do health equity work without dealing with these three huge building blocks. And so we continue to keep them in the forefront. I mean, I used to say I did this work so that my sons would not have to do the work. My sons are now young adults, professionals in their 20s. So now I say, let's do the work so our grandkids won't have to do the work. We dropped the ball, I would say, as a generation. We didn't get it across the finish line, the goal line, but we're still pressing, hopefully, for this next generation to see change. So what does advancing health equity look like? What does change not just look like, but what does it sound like? And what does it act like? What should we be seeing differently? What should we be saying differently? What's the change in narrative? What should we be doing differently? So I just want to end my talk with some summary around that space. So yes, seeing differently. And this is, again, this place of intentionality. And this is, I just want to give you two examples of how we must train our seeing, right? This is a poster that the American Red Cross put out a few summers ago. I was a member of, this is the National American Red Cross, but I love the American Red Cross. This is not a Red Cross bashing moment. I used to be on our board of our American Red Cross in my community, but it is how we are just all sort of programmed, right? So be cool, follow the rules at the start of summer. Let's have pool safety, prevention messages, absolutely. But if you look more closely at this poster, you will see, and if I was with you, I'd have a poster and I'd point out the things, but you would see that all of the not cool behavior was the Black and brown kids. And all of the cool behavior was the white kids. I know you're having conversations out west about implicit bias, right? So it is implicit. How do we deconstruct this? How do we begin to see things differently and immediately so that change can follow? Now, here's another one, and I'm going to just have you ruminate on this yourselves. And I don't know if I can still see the chat while you guys are, while you're doing this, because if you can see it, throw in the chat box, what is this an image of? And I'll let you just think and reflect on it for a second. What is this? It is actually a picture. It's not like a Rorschach spot where you get to be interpretive. It is actually a picture of a thing. So throw into the chat box what you think this is. Kat, I don't know if you can help me while they're doing that. And and yeah, can you read off what some of the things that are being added?
Yep, I am currently have the chat open. I see it starting to come in. I see aerial picture, abstract painting, an X-ray, a map. All I can think of is a bear, clothing, a face, map, a black and white photo of a palm, a person, a white man, a Google picture aerial.
Yeah.
Person on left. Snow on a mountain.
Snow on a mountain. That's got to be contextual because y'all have beautiful snow-capped mountains out there. Well, let me tell you, the person that said it's a bear, it was close. It is actually a cow. What? So if you, let me try to describe this and hopefully you'll be able to see it. So that black spot on the far left side of the picture is an ear. And it follows down a curve, which is the bridge of the nose of the cow. And at the bottom of this picture, there are two nostrils. The other little black spot in the kind of the middle of the picture is the cow's other eye. So if you don't see it, when you download my slides, you can keep looking at it. But anybody seeing that? Can I see if there's some thumbs up, Kat? You see anybody going, oh, right. Anybody seeing it?
Yep, sorry, I was on mute. So I see a lot of people, I've seen some people say, wow, cow. I see it. Yes, there it is. Thanks. Oh, wow, I see it now. Oh my God, I see it. It's much clearer now. I see it. Now I see it. I didn't see it all before. And then some people are still like, I don't even know. I can't even see it.
at dinner and you can discuss this with your family. Do you see a cow? But it is about training our eyes to see, and I'm convinced that we can train our eyes to see racism. We can train our eyes to see classism and oppression. And may I just say to you, if you have a person that says racism does not exist, there's no racism in this society anymore, instead of getting frustrated or angry or irritated with them, just know that they're in need of education. They're in need of relationship with someone like you who gets it and sees it and understands it. Nobody's getting mad at the people that can't see the cow. We just know they need a little bit more time to see it. And I bet maybe if you grew up on a farm, maybe you immediately went to a cow. Yep, I saw this. Or if you saw this before, you immediately went to a cow. Because once you see a thing, you cannot unsee it. So we're in this space where we're just challenging ourselves and our colleagues and our peers and our families and our friends to just pause and see things differently. That is how we're going to advance health equity. So if we move on from seeing differently, well, let's see here. I don't know if I did something. Oh, there we go. To saying differently, right? What is the shift in the narrative? And, you know, can I say nobody wants to be called a racist? But there are people applying racialized racist behavior, maybe intentionally, maybe not intentionally. We've had some beautiful weather in Michigan, and I went up north to northern Michigan where it's very lush, and, you know, we have a gazillion lakes in Michigan, including the Great Lakes. And I have a close friend whose family has a boat, so my sons and I, who've been quarantining, their family, who we knew had been quarantining, we went up to just hang out on the boat for a day. And he was telling us that when he stopped, this happens to be an African-American family, when he stopped for gas, that someone pulled up next to them and leaned out of the window, and the woman literally just started yelling at him and his family, N-word, 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 over and over and over again. Racism does still exist in this society, and COVID has sort of shined the light on things. So that was an interpersonal exchange. But you have people that have those type of beliefs that somehow or another this race is more gifted, more talented, stronger, better, then they have to have someone to think as a race is less than. But you have folks in powerful positions that have unawakened mindsets, and those attitudes impact the policies and the decisions and the systems that are being constructed. And if we have old systems that were constructed where racism was the norm and we've never changed the system, then the system is going to continue to be racist. So that's what we're saying. Eduardo Bonilla Silva is an author of a book entitled Racism Without Racists, because no one is confessing, well, yeah, you got me, I am a racist. Very few. I mean, there are some white supremacists that do say, yes, I'm a racist, but very few, right? But this is where we're trying to push people to say, well, what is the change in the dialogue that has to happen? And one of the things that limits us, I think, from having this dialogue is people are nervous about, what do I say? And having answers and being well informed. But I would submit that the initiation of this dialogue is not about having all the answers, but it's about having questions and just throwing out the questions. And then you evolve, the answers evolve with us. So I'm going to offer you, I'm going to just throw these all up at the same time, that we've been sort of socialized to ask those questions under the blue. Who lacks access to healthy food options and why? And we're submitting that it's not a bad question, but perhaps we should also ask, what are the policy changes that would redistribute healthy food resources more equitably in our community? Instead of just asking, how do we connect isolated individuals to social support? Let's ask, what are the institutional policies and practices that maintain rather than counteract people's isolation from social support? When you look at some of the policies around justice-involved individuals or formerly incarcerated people, we force them into isolation once they are released because there's so many spaces that they cannot live in, regardless of if their family or their support systems are living there. Why do people smoke? Very important public health question. We know that there's research that if physicians say to patients, do you want to stop smoking? If so, I can help you, that even that opening of that door helps people enter that pathway of prevention. Instead of just asking that, why do people smoke? We should also be asking, what are the social conditions and the economic policies that are predisposing people to the stress that encourages smoking and also the stress that encourages substance misuse, right? Why do people drink so much? Sometimes we just come from a very judgmental space. Well, what are the policies and zoning practices that reinforce the the disproportionate presence of alcohol selling outlets in vulnerable communities? If all that's in your community is McDonald's, then you're probably going to eat more of McDonald's. If all that's in your community are alcoholic beverage stores with maybe chips and things, then you're more likely to engage in those. So it is this both and space of what is the sort of downstream question, right, in the blue, and what are those upstream, mainstream questions that we need to get at in the purple. So that's saying differently, seeing differently, saying differently, and now let's think about doing differently. I want to just give you a couple of more examples. This is some research from Howard Koh, who's a former assistant secretary of health nationally, and now is a professor at Harvard University. He did research on public health leaders and came up with two characteristics as one of his findings. And he says, you know, public health leaders are generally driven by a profound and fundamental sense of mission. I mean, we laugh sometimes and say, you know, we didn't get in this for the money, right? Yeah, it's about the mission. But he also says that there's this sense of purpose in individuals like us, in professionals like us, that motivates them to leave the comfort of the sidelines and wade into controversy. You are working, I mean, touching the work of substance misuse is pretty controversial. People don't want to help addicts. And how do we say, you know what, this is my mission, this is my purpose, my professional and perhaps personal purpose, and here's why I'm willing to jump in. So let me share with you some reasons why I think people don't enter the controversy. And Margie Warrell did research on risk-taking, because the work that we're doing, and quite candidly, the prevention messages that you're trying to push, particularly to policy makers, it's much easier to get funding for naloxone, right? All of that money came in, shroom, really fast. Money for better treatment, for prevention, for looking at stress in homes, for looking at generational trends around alcohol use and substance misuse. It's hard to get money for that. So we have to be really bold and really intentional risk takers. And Margie Warrell talked about 4 things that she thinks causes people to not take risks. And the first one is, she says, that we overestimate the probability of something going wrong. Like, I'm not trying to bungee cord jump because surely it will break. Last night I found myself watching this interesting show called Married at First Sight, where you just meet somebody. They got matchmakers and they just meet. So this new couple that had just got married were on their honeymoon and they were going to go zip lining. And the wife was all for it and the guy was like, I don't know about this, right? That's risk-taking and the willingness. But you just overestimate that the zip line is going to break, or you overestimate that the bungee cord is going to pop, right? The other thing that Margie Warrell says, that in addition to overestimating that something will go wrong, you underestimate or you overestimate also the consequences of what will happen if it does go wrong. An elephant falling off a tightrope, that is probably going to be a huge mess. But maybe there's like a ton of trees below, or maybe there's some mattresses or something. You know, we exaggerate the consequences of what might happen if it does go wrong. The third thing she says is, you know, it might go wrong. Something absolutely might go wrong. When you're having a conversation about racism, it might absolutely just end up splattering all on your face. But she also says that we underestimate our ability to handle the consequences if something does go wrong. You really can't steer this thing to a safe landing. The bungee cord might break, the elephant might fall, but you are able to handle it just because of who you are, just because of what you do. When you allow, again, authenticity and your values to come into the forefront. And lastly, Worrell says that one of the reasons why we don't take risks is that we discount the consequences of inaction. That little fish could say, you know, I'm good, I got my little bowl, I'm fine right here. But what are the consequences of not getting into the bigger space? What are the consequences of not dealing with equity from a very authentic root cause place, making that upstream conversation the mainstream and not just being content with, yes, what was our distribution plan for naloxone? It's an important distribution plan to have, but it's not the end of the matter. So a couple of last points, getting upstream to the mainstream. One, I want to encourage you to recognize that treating the consequences of inequity through programs and services alone will never, ever eliminate health inequity. It'll keep us all employed, but it will never, in and of itself, program after program after program, eliminate health inequities. Mandate a reexamination of public health priorities, practices, and the uses of resources. That's how we get upstream, mandating a reexamination. Stop doing the same thing over and over again. We get upstream by communicating facts about the forces that produce or undermine health to constituents, public. We see it as the responsibility of public institutions, and we have those conversations with political leaders. And then we develop a policy agenda for health equity and identify strategic activities with constituents that support the agenda. We are all voters. We're in the middle of preparing for an election season, right? It's all upon us. What are we doing as constituents to advance? And then lastly, how do we engage with communities to develop their capacity and their resources to participate fully in social and political processes? Communities don't want things done to them. Are you that governmental programmatic entity that's, we're so good we did this for community, or are you doing this with community? So think about the point that we know that racism can be eliminated. We know that inequities can be eliminated, but do we have the political, professional, and the social will to get out there and do it? I just came across this quote, and I just want to close with two quotes. I am a quote person, by Craig Groeschel, who is a pastor and a leader consultant, leadership consultant. And he said, leaders see problems, but they seize opportunities. And I would submit that COVID is a huge opportunity for us as a nation. I mean, if I had been asked last year, could I convert my 600-person public health institute into a telecommuting space on a dime within 2 weeks, I would have said, absolutely not. We got to plan it out. We got to think it through. But did I do that in 2 weeks? I sure did. I saw the problem and we seized the opportunity to do what was needed. So how can we take these lessons of, you know, in public health, we talk about rapid response teams and are executing those all over the nation now in response to COVID. How do we execute rapid responses to begin to see change happen quickly on behalf of the folks that we are supporting and advocating for? And then lastly, I just want to share this Martin Luther King quote, and he says, I have the audacity, and I love that word, right? I just have the nerve to believe that people everywhere can have 3 meals a day for their bodies, education and culture for their minds, dignity, equality, and freedom for their spirits. And I used to end the quote right there until I kept reading one day and was so encouraged personally by how he ended that statement. The following sentence in that speech of his says, and I believe that what self-centered people, he says men, have torn down, that people other-centered can build up. And I believe that you and that I and that we are those other-centered people. Based upon that word cloud when we opened, I believe that we are the ones that see ourselves building up a system that values, appreciates, positions, and helps people achieve health. So thank you guys for your time today and for listening. And with that, I will turn it over back to Kat.
Perfect. Thank you so much, Dr. Canady. It was incredible getting to hear you speak again. That was so inspiring, and I want to thank you again so much. It's just, every time I get to hear you, it's an incredible experience, so thank you. I also see that we have a lot of people coming into the chat thanking you. I don't know if you can see that now, for your wonderful presentation and your amazing words. It was just, thank you so much.
My honor.
We'll hope that you join us for other parts of the day, if at all possible. We'd love to be able to see you. And of course, if anyone has any questions, they are more than welcome to put it into the chat, or Dr. Canady has a speaker profile here on Whova, excuse me, and you're more than welcome to message her and get any answers that you may have. And we highly encourage you to do so. She is incredible. So thank you. And I'm just going to go ahead and share my screen again, and I'll remute you, Dr. Canady. And so next up, we would like to welcome our special guest to talk about some of the amazing work that's been going on in Southern Nevada and to send us on our way as we go about the rest of our day. But we want to welcome special guest, Congresswoman Susie Lee. Representative Susie Lee was born to a working family of 10 in Canton, Ohio. A product of the public education system, she attended Carnegie Mellon University, where she used a combination of scholarships, loans, and part-time jobs to pay for her education. Representative Susie Lee moved to Las Vegas in 1993, where she became an education nonprofit leader. She worked to improve the education system, decrease school dropout rates, and provide after-school programming for Nevada students. Her career taught her how to take on tough problems, roll up her sleeves, and bring people together to find solutions for Nevada's problems. In Congress, she is fighting to improve our education system, honor our promise to our veterans, and tackle rising healthcare costs. Representative Lee believes in working across the aisle and bringing people together to solve problems, which is why she joined the Bipartisan Problem Solvers Caucus. She now lives in Las Vegas with her husband, Dan, and their 2 children. Representative, the floor is all yours.
Okay, thank you. Can everyone hear me? It looks like I'm on. So
we can hear you loud and clear.
Okay, great. Thank you, Katerina, for the introduction, and Dr. Canady. That was I didn't get to see your whole presentation. I got on a little late, but I'm looking forward to following you in the future. I thought your remarks were incredible, so thank you. And I'm honored to be with everyone here who is online because you are our safety net on the front line. And I'm sure back in January that many of you could not fathom conditions that would make your jobs even harder. But substance misuse and the overdose epidemic in our nation has now taken on a devastating new dimension. This crisis has collided with another public health emergency, and that's the COVID-19 pandemic. According to the American Association of American Medical Colleges, COVID-19 pandemic has worsened conditions that lead many Americans to substance misuse, including, I quote, anxiety, grief, isolation, financial worries, changes at home and work, and an ongoing sense of security. And in July, the national laboratory service provider, Millennium Health, announced that it analyzed 500,000 urine drug tests before and after the pandemic was declared a national emergency. And they found a 32% increase in non-prescription fentanyl, a 20% increase in methamphetamine, and a 10% increase in cocaine. And we all know that these disturbing national trends have not spared our state, Nevada, especially when it comes to fentanyl and drugs that mimic fentanyl. In the first half of this year alone, Clark County tied the number of fentanyl related deaths in all of 2019. Dr. Gloria Wong Pat, Director of Gambling, Addiction, and Marginalized Community Lab at UNLV, said this quote, which we all know, that people get into addictions for two reasons. Life is either too hard or life is too boring. So it's not a surprise that we've seen an increase in overdose deaths since March. On top of that, we know, as all of you know, because you're part of it, that a strong support system is key to recovery success. And many people who have lost their jobs have also lost their health insurance, making it even more difficult for them to seek treatment. And we all know that catastrophe has hit our state socially and economically. We have rampant unemployment and declining state revenues. And we have a predicted $1.2 billion funding shortfall for this year alone. And we all know that cuts have come and will continue to come in critical services like Medicaid that are so important to the work that you do. That is why in the House of Representatives, we passed the HEROES Act 3 months ago with that would mean that Nevada would get about $8.7 billion in state funding. So it is critical. I know negotiations are ongoing right now with our leadership. It's so critical that we reach an agreement and we continue to fight for state and local funding. Another thing that got included in this bill was my bill, which would increase the federal match for Medicaid to 14% for those states that have high unemployment rates. So I will continue to keep our community posted as those negotiations are ongoing, but I'm hopeful we can get to an agreement. But we cannot talk about fentanyl misuse and overdose without talking about that door opener, which is prescription opioids. And for years, pharmaceutical companies have peddled opioids like oxycodone and hydrocodone without being honest about their true negative impact on people's health. And that was the first to fall for many Americans who are now experiencing opioid addiction, and for those who have sadly lost their lives to it. And although deaths involving prescription opioids have fallen, and that is a good part of our story, there's ample evidence to show that prescription opioids were the precursor to the rise of fentanyl use that we see today and the trend that we're seeing in Nevada as well. The role of prescription opioids in this crisis is one of the main reasons I co-sponsored the John McCain Opioid Addiction Prevention Act, which would require practitioners to agree to limit the supply of opioids prescribed for the initial treatment of acute pain as a condition of obtaining or renewing their registration with the DEA. And another bill that I co-sponsored was the State Opioid Response Grant Authorization Act, which reauthorizes the fiscal 2024 year 2024 in the State Opioid Response Grants Program. It increases access to medication-assisted treatment by using 3 FDA-approved medications for opioid use disorder treatment. It reduces unmet treatment, reduces opioid-related deaths through prevention, treatment, and recovery activities for opioid use disorder. In addition, we have another act that I co-sponsored, the No Pain Act, which also combats this crisis by promoting access to non-opioid treatments in hospital outpatient sessions, which we know having alternative choices for pain management is so incredibly important. Every single one of these bills, in the introduction, I was introduced as part of the Problem Solvers Caucus. My commitment to bipartisanship is so true, especially when it comes to an issue like this. And every one of my bills has bipartisan sponsorships. And that, to me, should be a relief to all of us, because there's another connection between substance abuse and the overdose epidemic and the COVID-19 pandemic, that the only way we can get through these crises is working together as a community and coming together in a strategic way. And that's why an event like this is so incredibly critical. And my deepest thanks goes to the Southern Nevada Opioid Advisory Council, the Southern Nevada Health District, PAC Coalition, and the Nevada High Intensity Drug Trafficking Area for understanding the central role that collaboration plays in the fight, in this fight, and for bringing us all together today. I also want to give recognition to Katarina Pulver, Jessica Johnson, and Jamie Ross for embodying that spirit of collaboration that made this event possible. Thank you all for all your hard work. It's no secret to anyone who's listening, the divisiveness and the discord in our national politics. And Congress isn't the first place that comes to mind when you think about collaboration and working together. But when it comes to issues like substance misuse and our overdose epidemic, I am so grateful that there are members of Congress across party and ideological lines who understand why we need to put our differences aside and tackle this issue head on. I mean, substance abuse and overdoses does not care if you're a Democrat or a Republican or an independent, or if you plan to vote or you don't plan to vote for one candidate or another in any election. And at the end of the day, it's so rare to talk to anyone who does not have a loved one or a family member battling addiction. And each one of you have experienced, I'm sure, the heartbreak that substance misuse and overdose epidemic has caused for spouses, partners, moms, dads, brothers, sisters, and friends. And that heartbreak is only human, and with a sense of compassion, and it's with that sense of compassion that we need to come together and find solutions. And I personally believe that needs to start in the halls of Congress. That's why I took a step when I first joined to be a member of the House of Representatives Freshman Working Group on Addiction. This is just to give you some background. Congressman David Trone has a nephew who has battled with addiction, and he is a good friend of mine and started this working group. And so I encourage all of you to follow his work in Washington, because this is the single reason he ran for office. And so I've been proud to continue to work with him and Democrats and Republicans who get it and are committed to putting politics aside to help our constituents who are struggling with this illness. And the need to work together is a big reason why I co-sponsored the Comprehensive Addiction Resources Emergency Act. This bill will provide federal emergency help to state, local, and tribal governments that are struggling with this epidemic. It also provides funding to state, local, and tribal governments and public and private nonprofits to organize and coordinate effective systems that deliver the critical services to people and their families who are struggling with substance abuse disorders. And we can't talk about substance abuse or the overdose epidemic without mentioning the disproportionate impact that it has on our veteran community. The link between substance misuse and suicide is well established, and in no population is that clearer than among our veterans. Instead of providing our veterans with comprehensive treatment for injuries, mental health conditions, and chronic pain, our country has recklessly decided to overprescribe them with highly addictive painkillers. And I'm a member of the House Veterans Affairs Committee, and I worked very hard with my colleagues from both parties to ensure that our veterans get the help they need so they don't become another statistic. Our veterans put their lives on the line to protect our country, and the very least we can do is provide them with the health care and resources they need and deserve to fight substance abuse. And as you all know, I've lived in Southern Nevada since 1993. And if there's anything that I admire about this community is our ability to come together when going gets tough. And I want to expand on what Dr. Canady said. With so many, I'm just going to say national disasters, which is what this is, so many times when we are tried as a country and as a community, there are also pockets of opportunity. And I believe personally that we have seen an incredible move towards telehealth. And I think that that is a big opportunity, especially for this community who is working on substance abuse disorders. I think that it will open up access to many individuals who may not have had it. But I also believe, and as many of you know, that we will continue to have to work together to deal with the pressure of isolation versus access to critical services. But I can't tell you how happy I am to be here with all of you and to have a chance to speak to you. Many of you know my background has been, I started out working in homeless programs, then after school programs, and now prior to running for Congress, dropout prevention. And so many families struggle with substance abuse and addiction. And honestly, you know, we keep saying it takes a village, but it certainly does. And so I know that with all of you on the front line continuing to work together, that we will come together despite the trying times, despite the threats to our state and local funding. And I just encourage all of you to make sure you lobby or have friends who are in other parts of the country who may have senators who are not moving on the HEROES Act to advocate to get that state and local funding, because it's so incredibly critical to the front line and to the work that you're doing. And but I just say that, you know, I opened up with basically saying we could never imagine our jobs getting any tougher, and this pandemic has certainly delivered us a new dose of reality. But that being said, I know that we come from a community that works best when we work together. And I won't lose hope that we will get through this together. We will come out of it stronger and better. We will be tested to learn how to work in smarter ways, work in different ways to make sure we're getting the critical services to the people who need it most. So I'm proud to serve Nevada and to serve this community because I know that we have that fighting spirit and that collaboration and that sense of community. So thank you all for all you do. Continue to keep your spirits up, and I'll continue to fight to make sure that you have the resources you need to help us stop this epidemic. Have a great day, and thanks for including me.
Wonderful. Thank you, Representative. We appreciate your amazing words today and in welcoming us to this summit. So I want to go ahead and thank everyone again for attending this opening plenary. I love all the feedback that we got, and this is just amazing. Once you go ahead and exit out of this app, or once you go ahead and exit out of WebEx, you'll be redirected back to the web app page, and you're more than welcome to join any of our breakout sessions. Just go ahead and you'll have Zoom and WebEx rooms available. Again, we highly recommend that you join via Google Chrome to the best of your ability so you're able to see all the sessions. But if you have any questions or anything, go ahead and message me directly in the app and I'll be happy to answer them. Thank you so much, and you'll have a wonderful day.